Hello and welcome everyone. I'm very, very sorry for a little bit of issue. I have a little bit of a problem with the sound, but we are here. So please just confirm that you can hear me loud and clear. And as you can see, we have another special guest with us tonight, Dr. Christos Roukoudis. I hope I said it correctly. Is with us. Hi, Dr. Christos. How are you feeling tonight?
I'm very well. Thank you for asking. Nice to having me. And also from my side, also sorry for the delay. We will try to do our best to make up for it. So
for sure. So again, really sorry about this. Sometimes it's out of our hands. As you know, it's a live event, but please confirm for us that you can hear us perfectly, because we definitely want to go ahead with this webinar. And of course, Dr. Christos has prepared a presentation. He has 2 cases that he will discuss thoroughly, but afterwards there will be time for your questions. So just remember, you can type those in the chat section and Dr. Christos will answer them for you. So thanks a lot for staying here with us and for your time already, because I know you've been waiting over 20 minutes. So I will leave it to Dr. Christos right now. Let me just mention that he's the gynecologist at IVF-Spain, located in Alicante. So we are we are connected with Alicante, and I'm very, very happy that it's working. I think it's working, which is the most important thing right now. Thanks so much, Dr. Christos, and let's get going with the presentation, okay?
Thank you. So, again, first of all, good evening from Alicante, and to all of those watching our webinar today. And we will devote ourselves to a very interesting topic, and this is recurrent implantation failure, and I will share with you some success stories. Let's get into it. So we start with the definition. What is it exactly? What is a recurrent implantation failure? The definition is that it's defined as a failure to achieve pregnancy in women younger than 40 years old after having transferred at least 3 good quality embryos in both fresh and frozen cycles. And also very often in the history of the couple, it's very characteristic that it never came to a pregnancy. Also, it's very important to exclude the condition that are not belongs to this spectrum. To those belong the advanced maternal age, so women after 40, diminished ovarian reserve, low quality embryos, underlying medical conditions like severe endometriosis, or big fibroids, or some polyps, and also an insufficiently built up mucosa. So endometrium is one of the key factors, and I will go into the details later. So now, to known causes. First of all, blood clotting alterations, like hereditary thrombophilias, like factor V Leiden, factor protein mutation, protein C or S deficiency, immunological alterations. Here we have the antiphospholipid syndrome. We have also some other things, for example, KIR HLA constellation that is not favorable, celiac disease. The uterine factor here is, for example, a shifted implantation window to mention, chronic inflammation, and of same importance is also the male factor. With the opportunity to have an advanced spermiogram, we can find out, for example, also how fragile the sperm is, and to select to do something about it with medication, and also to select afterwards the best embryos. Also, very important is the embryos that we transfer, one of the most important reasons, and that those embryos that we transfer have the highest quality. There are two yardsticks here. On one hand, what we can see with the naked eye, for example, that an embryo has developed a beautiful blastocyst, the 5 embryo, but moreover, when the reproductive female age is advanced, so above 37, 38, a genetically testing of those embryos could be very helpful and could be also the game changer that allows us to transfer only genetic healthy embryos, and so to increase the chance for implantation. So here's also, but it's also important to say that a sufficient egg reserve should be there because the PGTA is not flawless. Then, regarding the importance of the PGTA, we can see also that with advanced age, the rate of unhealthy blastocysts increase, and the risks of so that the possibility for implantation that will not occur is very often very high. Okay, so this fact can be, as I said, also a reason for implantation failure. Let's jump into our first case study. There's nothing better for me than to arrive at the destination with the couples that I accompany, especially if it was a long journey. And so today I may share some of this joy with you. We have this couple. The girl was 39 years old. The AMH is an indicator for the ovarian reserve, together with the AFC and the age. So the AMH and the Mullerian hormone is a hormone that is produced from the follicles itself, from the eggs inside of the follicles. 0.8 nanograms per milliliter is a quite low number. The IFCs, the antral follicle count, is the number of follicles we can see on the first, second, third day of the cycle. It was in both ovaries. We have a total of 5 follicles. The husband is a bit older, 43, and had oligoastenospermia. I will explain in a few seconds what does it exactly mean. About the common history, fertility history, they tried to conceive for 3 years, 2 previous IVF cycles at home. They produced 3 blastocysts. They were transferred, all of those of good quality, and the result was always negative. So the first step was to start with a proper investigation. An investigation in first, for example, the blood clothing. We did the necessary adjustment and screened for hereditary thrombophilias. The result was negative. For deficiencies for protein C, protein S also was negative. Antithrombin was also negative. Then we concentrate in the investigation of the immune system. We screened in the blood for certain antibodies that are characteristic for antiphospholipid syndrome. They were negative. And then we searched if what's the KIR type of the patient. It was a KIR-BB. Again, I will explain it in detail afterwards, only for you to have in mind that KIR-BB is not related with higher risk for implantation failure. Then we looked also if a celiac disease is there. Celiac disease is an intolerance to gluten. Sometimes it's related with symptoms, sometimes it's without symptoms. So for example, if somebody who has a celiac disease, as I said, in this collective who has symptoms, eat pasta, eats bread, sometimes they have cramps, have strong pain, and we know that in those cases of celiac disease, we have high antibodies against transglutaminase and gliadin, and those antibodies can prevent from an implantation. We screened for them, they were also negative. Then, regarding the thyroid, we looked for the TSH. We know that this number is in the normal range, this value. So normally, if we are outside of a pregnancy or a patient is not trying to get pregnant, it's totally fine. But if a pregnancy, if they wish to achieve a pregnancy, then the value should be lower than 2.5. So we started with L-thyroxine, 25, the lowest dosage, and after 3 weeks we controlled again, it was okay. Something else. Also, we did an investigation in the karyotype. Karyotype is a mapping of the chromosomes. It looks like this. I do it always before starting with a stimulation, because the couple can look normal, but there can be some alterations in the chromosomes. We can have, for example, an additional chromosome somewhere, or one of those, one part of one chromosome can be on top of another. All of those anomalies can result in the produce of unhealthy embryos. So if we know this fact, then also we know that the possibility to have unhealthy blastocysts is higher, and those blastocysts or embryos have a smaller potential for implantation. Afterwards, we did an investigation at her partner. We did a spermiogram to see how the quality of the sperm is. We saw that the volume was 1.2. From the World Health Organization, the threshold is 1.5. So, but it's okay. The concentration was 35. Here the threshold is 50. It was a little bit less. The motility should be 39. It was 32. Also a little bit less. The normal shaped sperms should be not less than 4. It was 4. But we can work with it, so it's not a very bad result. Regarding the karyotype, we did it also as mentioned, and we saw that the karyotype was normal. One thing that we also did in addition was complementing an advanced spermiogram that allow us to make even more statements about the quality of the sperms. We investigated the DNA fragmentation and the apoptosis. DNA fragmentation is how fragile is the DNA inside of the sperm heads, and apoptosis is the programmed cell death, and both of them were in the normal range. If we have, for example, a higher DNA fragmentation, we can use antioxidants, and it's very helpful, and we are able to bring it in the normal range. So after all of this diagnostic, we started with the first IVF cycle. We used gonal F So this is FSH 150 and Pergovirus is FSH and LH, both of these for almost 10 days. I gave my patient growth hormone, it's Cytsen, it's 10 milliliter during the stimulation every second day. I did this because from studies we know, and from our observations also, that the implantation rate for sure at patients with a low ovarian reserve can be increased at least at 15%. So I give it very often to patients with a low egg reserve. Also, in addition, organotran to prevent the patient from ovulating during the stimulation, and for the triggering after those 10 days, I used tryptophan. During the egg retrieval, I did also a hysteroscopy and an endometrial biopsy. The reason for that was there's a clear indication when we have implantation failure to do a hysteroscopy, and the result were normal. We could also combine it during the one procedure to do also hysteroscopy, and with endometrium biopsy, we were able to estimate also a few things. For example, the implantation window, the immunological behavior of the immune cells inside of the lining. I will dive into it further during the presentation. And but what we were able to achieve is to get two very nice embryos of very good quality, 5AB, 5BB. About the results of the biopsy, the ERMAP is the endometrial biopsy to find out when exactly is the best time to transfer one of those precious embryos. We know that during the female cycle, estrogens are produced by the maturing follicles, which cause the endometrium to grow. The luteal phase begins with the ovulation, so the second phase of the cycle. The corpus luteum produces progesterone, which makes the endometrium receptive to the fetus for a certain period of time. We know that in 70% of the women, this is after 5.5 days of progesterone release. In the rest, it can be after 6.5 or 5.5 or 4.5 days. This can be found out with this ERMAP test, and the embryo can be transferred accordingly. It's especially important to do this test in case of implantation failure. In our case, she was receptive after 5.5 days, so perfect. And the other findings through the biopsy were culture that we did from the cavity of the uterus. They showed us everything was okay, and also immunological screening in the line. We know that the dialogue between the incoming embryo and the white blood cells that live inside of the lining must be proper so that the embryo is allowed to implant. So we were able to find out that this is how it looks like, and there are several cell population, white blood cells population, and all of them were fine. So we did the proper investigation, the biopsy with the estimation, with the confirmation of the implantation window, the study of the immunological behavior of the lining. Also, we rule out a chronic endometritis because we were able to outrule plasma cells in the findings. Also, we saw that all the natural microbes that are inside of the lining were okay. So we did our homework, and we did a pause for a month. The idea was now, because of the results that we had, to collect embryos so that we were able to increase the possibility for success. We know that, as I mentioned before, with increasing age, the egg quality drops. And not only this, the number of unhealthy embryos increase. We know that when a woman is 40, almost 20% of the potential embryos that are there are unhealthy. 80% unhealthy, 20% only are okay. So I show you again, we were able to have 2 embryos. So for us to have realistic chances for success, we needed more embryos. So we agreed to do a second cycle, collect a few more embryos, and test all of them genetically to find for sure the healthy embryos, and afterwards having a chromosomical healthy embryo with normal chromosomes, the possibility for success is much, much higher. So, as I said, we did a pause for a month, and after that, I gave my patient an anticonceptive pill for like 14 days to downregulate her. We did a basal scan, so a scan after she stopped with the pill. After 5 days, more or less, she had a menstruation. We did a scan, and I saw again only 2 follicles. So I told her, okay, we will not use this cycle. We will skip this cycle and look after in the next cycle how it is. So we did this. I gave her again for like 14, 15 days anticonceptive pill. She stopped again, and then we were able to find good cycle with 7 follicles. So we started the stimulation. So important, and also important message here: if the egg reserve is a bit low, we not use any cycle. Instead, we wait 1, 2 cycles until we have a suited one for a stimulation. So we stick to the same medication because the outcome was pretty good before. So how it is, do not change our winning team. So the same medication. We did egg retrieval after 10 days, and we got 3 also 3 good blastocysts from which had very good quality. So all of those embryos, the 3 blastocysts that we got from this cycle and the 2 blastocysts that we got from the cycle before, we did a test, and then genetically test a PGTA, so a pre-implantation test for aneuploidy. And what we found out is that out of those 5 embryos, only 2 were suited for a transfer. So this fact also confirms the findings that are mentioned in all of the studies and everything that we here observe, that 20% only is healthy. So 2 out of 5 is very realistic. So we prepared to transfer one of those euploid embryos. The endometrium thickness was pretty good, 7.5 millimeters with 3 layers. Progesterone was also very good, and the result was positive and a healthy baby boy. Spontaneous delivery in week 39, 38 plus 5, and with normal weight. So the delivery was almost 2 years ago, 1.5 years ago, and now the patient has contacted us because she wants a second child and wants to proceed with the transfer of the second blastocyst. And what we can see here is the importance of an embryo banking, that not only we're able to increase the success rate transferring a genetically normal embryo, also we must have in mind that the couple is now 2 years older and the ovarian reserve diminished even more. So if we attempt a new IVF cycle, it will be more difficult to generate healthy blastocysts. So we achieved success, and patients and also doctor were in the end very happy. Okay, let's now jump to our next success story. It was our young couple, a girl, 30 years old, an AMH of 3.5, 3.4 nanograms per milliliter. The antral follicle count was pretty good, 25 follicles. The sperms from the husband was also very good, normosospermia. And regarding their history, they tried to conceive for around 2 years. 4 previous cycles, 3 IUIs, 1 IVF, 1 IVF with 3 transfers. All of those good embryos, 5BB and 5BA, were transferred together during the first attempt, and the result was always negative. They had a laparoscopy to rule out any the chromoperturbation to make sure that there's no block in the tubes, and also they did back home very basic diagnostic after the first transfer. Afterwards, I saw them in Alicante, and as you saw it before, I did again all the proper investigation. I started with investigation on the blood clotting, everything was negative. I started investigation for the immunological alterations, it was negative for the antiphospholipid syndrome. Regarding the KIR HLA constellation, I had the girl was KIR AAA. This could be important. I say could be because you will see it in the next slide. Regarding the celiac disease, I was able to confirm that she had a celiac disease without any symptoms, but the antibodies were elevated. The solution, as I mentioned before, very easy, gluten-free diet, and afterwards the antibodies decreased. Regarding the investigation for the thyroid, I saw that also here the thyroid, the TSH was elevated. I started also here with L-thyroxine. Sorry. Okay, and the sperms from the husband were pretty good. Nothing characteristic there. I did investigation for the HLA. HLA was C1, C2. In this combination, KIR and C1, C2, rather not favorable, not good. I did a karyotype in both, everything is okay. It was okay. So let's see what does this exactly mean, this KIR HLA constellation. The endometrium is home to various populations of white blood cells. Among them are the NK cells. The function of those NK cells is to regulate the growth of the invading fetal cells. Okay, NK cells, every woman has them. The thing what matters is the equilibrium also. There should not be very high, there should be not very low. So we have, it could be a matter of the number of the NK cells, but also of the type of NK cells. So regarding the type, the NK cells are divided in two main categories, two groups, according to the receptor that they possess. Those groups are then KIR-AA and KIR-BB. Each woman has one of those, belongs to one of those groups. By means of these receptors, certain molecules on the surface of the fetal cells are recognized by the NK cells. Half of those molecules comes from the partner and half from the partner, and from the patient. It can be C1 or C2. There are certain KIR HLA combinations that are more favorable for developing pregnancy than others. You see here, for example, that if a woman is KIR BB, she has NK cells which are not associated with increased risk regardless of the molecules on the surface of the embryo. So I do not mind if the guy is C1, C2, 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 C1, C1. Okay. The situation is somewhat different in women who are KIR-AA, like in our case. They have NK cells that have an unfavorable correlation with the C2 molecule of male origin, okay, and are associated with increased risk of implantation failure, early abortions, and also preeclampsia. Here should be emphasized that this relationship does not make a pregnancy impossible in couples who have it. It is only important to recognize the indications, in this case, of an appropriate history to initiate appropriate diagnostic and to adjust the treatment starting from the transfer. This means to transfer only one embryo, not to burden the female body with more C2 molecules, for example, from two embryos. So I don't know if you notice it. In the history, they had one transfer with two embryos. So afterwards, we know that it was not a wise idea. So, having all of this in mind, we did an IVF cycle, and we used FSH, Puregon, for 11 days under orgalutran. We triggered with tryptophan. Again, during the egg retrieval, I did a hysteroscopy and endometrium biopsy. I was able to get 14 eggs. Out of them, around 12 were mature, 11 got fertilized in the end, and we had very good embryos, very good quality embryos, of good quality. Let's see the findings from the biopsy. ERMAP. Again, the implantation. We found out that she was pre-receptive, so therefore we planned a transfer, not after 5.5 days, after 6.5 days. This could be, for example, also a reason for not achieving implantation. Now, the second result, the immunological testing of the lining. Here, we saw serious alterations in the population of NK cells. It was quite low, and in the ratio of Th1 and Th2 cells. After consulting with our immunologist here, we prepared a plan for immune modulating therapy, and we used additional medication. In this case, it was ACG, so Ovitrel, and we were also able to rule out a chronic endometritis again, and also to see that the microbes inside of the lining were also all right. So we did a transfer. We prepared the lining with estradiol, with progesterone, and we did the transfer after 6.5 days of progesterone. Regarding the lining was thick enough, 8.5 milliliters, again with three layers. The progesterone was quite good, and we transferred only one embryo. As mentioned, during the transfer, ACG, because of the alterations in the lining, and also we have a positive pregnancy. The patient had a delivery in week 40, 39 plus 4, a healthy baby girl. And here is also very important to see how important it is to do our homework individually and to draw the right conclusions so that the precious time is not lost. For the treating physician, it's extremely important to sharpen his eye for this and initiate the appropriate diagnostic. So individual treatment is extremely important to provide the patients with the highest possibility for success, and not doing same thing over and over again. We must find what is the reason for the implantation failure in this case, so to provide the patients the right answers to the problems that are there. With this, those are the locations of the several clinics from the IVF Life group. With this, I come to the end of my presentation. Warmly thank you for your attention, and I'm happy to answer all of your questions.
Happy to hear that. Thank you so much indeed, Dr. Christos. I know that you cannot hear me right, so please just try to call me. Let's do it that way, okay?
I need only few.
Perfect.
Sorry again, because of the trouble the problems that we have with.
It's exactly the. So just give us a second.
Must...
We needed to do it differently tonight. That's all. And of course, we will start our Q&A session in a second. And I see so many questions so far. So yeah, go ahead, type those in. Okay. We just need to wait. We want to make sure that Dr. Christos can hear me as well. So that's why we need to do it. As I've mentioned, we had some issues, and he's calling me right now, of course. And I guess you can hear me now, right?
I can hear you very well.
Excellent. Thank you so much. If you can just put the volume a little bit lower, just to make sure there is no much echo.
Give me a second.
Sure.
How is it now?
I think that it will be much better. Thanks so much. You will still hear an echo, I'm afraid. Apologies for that, but I guess we can start our Q&A session. Okay, thank you so much. Brilliant presentation. Great cases. Very interesting. And well, there are lots of questions about KIR, HLA, I see already. So I'm sure it's going to be an interesting discussion. So
I was pretty sure the KIR,
exactly.
HLA
When I saw it,
a bit tricky.
I was sure it's going to happen, but we are happy to discuss it for sure. First, the first question is right here. Is there anything to treat KIR AA?
Here is one of my take-home message is KIR AAA. It's not like the end of the world. Okay, we are able to give you some immune modulators so that we trick a little bit your immune system. Cortisone is a good option, and also some other immune modulators can also be very helpful. But for sure, it's not like if you're KIR and your husband has a C2 molecule, it's impossible for you to get pregnant. That's not the case.
All right.
I have patients, for example, where it's clear to see that the embryo quality is the problem, and the people insist on thinking that the KIR-HLA is the problem, this KIR-HLA constellation, but it's not. It's really not. And if we are able to provide you with a high quality embryo, KIR-AA, it's very often not an issue.
Okay, we have a follow-up. Do you ever use Neupogen?
Yes, but it must be a clear indication there.
Okay, thank you for the clarification. And can NK cells be associated with recurrent implantation failure?
Yes, they can be related. The NK cells, you must think about them as like the guards of your lining. The NK cells, they live in your lining. Okay, and they live there also in your blood, but then also the uterine NK cells, they're inside of the lining, and they're like the guards, and it's normal to have them. First of all, it's normal to have NK cells, but the amount of them is important, and also the type of them seems to be very important if they're what type of receptor we have. So the NK cells establish a dialogue with the incoming embryo, with incoming fetal cells. And this dialogue must be adequate, must be normal, must be without any disturbances, so that the NK cells allow the embryo to invade inside of the lining, inside of the endometrium. And if, for example, disturbances are there, alterations are there, we can have implantation failure, but we can have also other things like a preeclampsia. So they're associated for sure with implantation failure, and as I said, denying the embryo the implantation.
Thank you indeed for another question. And here's another one as well from Monica. I'm 33. We use surgically aspired sperm due to my husband missing vast tubes. Karyotypes are normal. No genetic conditions identified. Grades AA, AB, 2BA. Early blastocyst, no implantation with 4 embryos. Then chemical pregnancy with embryos 5 and 6 using immune protocol. What would you recommend to do next? Is it worth to keep trying with own sperm?
Let me read it another time very fast.
No
implantation with 4 embryos, 3 transfers. Okay, then chemical pregnancy with embryos 5 using immune protocol. What would you recommend to do next? I would start to look into your lining, to do, for example, the estimation of the implantation window. I would look in the immune system, immune behavior of your white blood cells inside of your lining. This is our EMAP test, for example. I would rule out a chronic endometritis. Also, all of this with one biopsy. I would screen for abnormalities in your blood clothing, also to rule out that you have a celiac disease. Hysteroscopy, if it hasn't been performed, would be also a wise idea. The TSH is also important to be in normal range. Also, it's interesting to know how your lining was. Was it thick enough? Was it with 3 layers? Those are important questions.
Okay, sorry, follow up here. Lining is always perfect.
Good. A biopsy would be a quick response. A biopsy would be maybe a good idea.
All right, Monica.
But you can, yes, if it would be also very interesting to know a few things about the case. So if you want, feel free to send us some few details also to our contact address.
Of course, as always. Thank you so much indeed. Monica actually has some more questions, okay? So let's go with those. What signal potential immune issues apart from failed implantation? Any symptoms we should be looking for also in Chicago tests? Is Chicago test a definite confirmation on whether or not immune protocol is required?
The Chicago test screens for many things, but our EMAP test provide us with some additional information. And also, it's very important the conclusions that you draw out of it. If the protocol that your doctor applies is the proper one. So it's not only to diagnose those things, also to treat them, not the treatment correctly. Okay, so about the potential immune issues apart, unfortunately, you don't see them. You don't see, any other symptoms. Maybe one exception would be if, for example, you have a celiac disease and you experience pain when you eat. You know that you experience pain when you eat bread or pasta. This is one example, but besides of that, unfortunately not. There are not some symptoms that will lead us to draw, some parallels to a failed implantation.
Thank you so much for yet another question. There are more, okay, from Monica. Is it possible that higher stem protocol affects equality? I had no embryo fragmentation with gonal 225, but severe fragmentation with gonal 200 plus menopause 75. We are using surgically aspired sperm. I'm 32.
Yes, for sure. We know that sometimes if we decrease the stimulation dose, the equality that we achieve is better. So you're a young girl, a young woman, and if your viral reserve is as good as normal as I assume, you should generate enough eggs also with a lower dosage. Exactly. And one other thing that we should do maybe is to make advanced spermiogram to advanced testing to the sperms of your husband, because it was aspired surgical, and maybe it could be the case that this is also this could be also a case, a possibility for the lower amount of embryos in the end. I don't know if it would be for you an option, for example, to use also for fertilization for a part of the eggs, maybe donor sperm. It's a hard decision. I understand it 100%, but it could be also a reason.
Understood. And one more, the last one from Monica, okay? Is it possible to PGTA test early blastocysts? My embryos don't often reach full blastocysts on day 5, so I keep transferring them fresh, but they never stick.
It's kind of difficult. Sometimes it's possible, but it depends how they look like and also from the skills from the biologist.
All right. Again, thank you for the clarification. More questions are coming up, okay? So here's the next one. Which microbiological cultures are normally found in the uterus? Can an imbalance in these cultures be the only cause of a recurrent implantation failure?
There are many different types of microbes inside of the uterus. It could be from E. coli, it could be from Yersinia, it could be 1,000 things. The important is the equilibrium also, that one population is not like very high. Normally, for example, E. coli in a very low amount will not cause any problems. But if it's, if it's a disbalance there and it's the dominant microbes inside of the cavity, then it can cause problems. Okay, so the ratio is also here very important to know exactly how the various microbes are represented in your cavity. Regarding the imbalance, it can be the case, yes, especially in cases where women had like very a good amount of manipulation in their cavity. For example, several hysteroscopies, several DNCs, several transfers. It could be that there is after that a disbalance. So it's a very easy. We take on only one sample, and after that we know where we are.
Excellent again, thank you. And Helen has another question. What could be the cause of initial successful IVF cycle resulting in live birth, numerous subsequent cycles which are resulting in chemical pregnancy only?
Here's interesting to know, when was the transfer? How many years ago, the first transfer? And something that we know is that after live birth, the implantation window can switch. So we do afterwards a biopsy. I do a biopsy, estimate when is the perfect time to transfer the embryo, and then according to the results, I do the transfer. Also, how many transfers did you have after the first one? And because there are also a few other information that I need. For example, it could be the case that those embryos were not okay, were not healthy, the other ones, and the one that you transferred was healthy. So it's not so easy to give you a precise answer to this.
Of course, thank you so much, Helen. If there's anything else, you know what to do. And let's have a look. More questions are right here. You excluded women over 40 from recurrent implantation failure diagnosis. I have transferred 11 untested embryos at 42, only one implanted, leading to early miscarriage. Surely this is recurrent implantation failure, not just age factor?
Of course, there can be also some other reasons, of course. But I don't want, to discourage you. We know that it was a big study. It came out, I think, 2012, 2013, and it showed us the relation of maternal age, female age, and normal healthy embryos, so chromosomal healthy embryos. And we know that when a woman is born, 20 years old, 75% of all the potential embryos that they produce are healthy, have the proper amount of chromosomes. When a woman is 35, 50% of them are healthy. When a woman is 40, 20% of them are healthy. When a woman is over 43, less than 10%. So the main thing, if I have a woman that she's 40 and I transfer untested embryos, most likely the reason for chemical pregnancy, for an early miscarriage, especially early miscarriage, the miscarriage happens in the first weeks. It's very characteristic for aneuploid embryo. So more likely this was the reason also in your case, but for sure you can't be 100% sure. It's not black and white. We must do the proper investigation, but if it's possible, also to do a PGTA test, because you got transferred 11 embryos. So it's I assume, I'm pretty sure it was like afterwards not an easy time for you. It's a long journey that you had, Manal.
Thank you so much. And there's one more question, okay? Let me go straight to this one. Can fibroids outside the uterine cavity affect implantation chances within the uterus? Do they interfere with blood flow or some other mechanism?
No. The possibility for that is extremely low for something like this. We must see to consider that a fibroid would be the obstacle for a successful pregnancy or implantation. Normally, you see it clearly in the scan or during a hysteroscopy that this fibroid affects the cavity. If it's outside, the uterus is a good is an organ that has a very high blood flow, and during a pregnancy, during also an early pregnancy, the uterus increases also the blood flow. So no.
Okay, one more. Okay, do you recommend hysteroscopy post-miscarriage? Could scar tissue be a factor in implantation failure following a natural miscarriage at week 8?
It could be the case. I recommend a hysteroscopy for sure, but only if you experience, several miscarriages. So if you had one miscarriage, it's not 100% necessary to have like a hysteroscopy. Here I offer something that I do, and it's very easy. It's a office hysteroscopy. During a consultation, it's not necessary to be in the operating theater. I can look into the cavity very fast and very straightforward. I have a result if anything is there that could be a hindrance or obstacle for implantation.
Again, thank you so much. And one more. Is frozen transfer proved to be better than fresh transfer in patients with who had implantation problems?
No. Fresh transfer in our clinic, and this is something that our success rates show, has exactly the same success rate as a frozen transfer.
Excellent. Thank you again for the clarification. Okay, next question, this time from Heather. Is treatment with corticosteroids a good strategy for RIF and counterproductive? Is the NK killer cell thing a real issue in your opinion? What about anti-cardiolipin antibodies?
Let's start with that, about the anti-cardiolipin antibodies. It would be to confirm the anti-cardiolipin antibodies are related with antiphospholipid syndrome. So to to say that okay, phospholipid syndrome is there, it's first necessary to repeat those findings 12 weeks after. So to do again a screening for the anti-cardiolipin antibodies and to see if they're elevated or not. That the phospholipid syndrome in the most cases is related not with early miscarriages, but with miscarriages in weeks later. So for the implantation failure, it could be important. So I start the treatment with aspirin and heparin, all this from the transfer cycle. And about your other questions regarding the corticosteroids, it's a good strategy, yes, because the corticosteroids have an impact in the immune behavior of your white blood cells inside of your lining, and yes, they are for sure helpful, and I give them after a transfer. The NK killer cell thing, you mean, what exactly you mean? You mean about the amount of them or the KIR HLA constellation? Both of them are important, and it's especially for patients who belong in this spectrum of repeating implantation failure. It's important to sharpen your eye as a physician and treat to offer a treatment, not to repeat, a transfer after another. But if, for example, I have a couple that is young and I do not do screening for KIR HLA and this constellation, it's not important. Okay, so there must be a clear indication to do things, not in Germany there's something that we say, you don't shoot with cannons at birds,
All right, thank you again for another interesting question indeed. An answer to this. Another question from Anal: do you test NK cells in blood as well as uterus? Which is better approach? Many reproductive immunology centers focus on Chicago test.
Yeah, the Chicago test is a very reliable test. That's true. Yeah, I'll be honest, I test the NK cells more in the lining, because there is where the dialogue between the embryo and the NK cells occur. So the immune cells in the blood shows very often the same findings like we find in the endometrium with the endometrium biopsy, but for me it's more reliable to test it in your lining instead of your blood.
Wonderful. Another interesting question. Thank you so much.
And this is also the reason, if, for example, the material after a biopsy is not enough to test it in the NK cells, to test the NK cells, then sometimes we test it in the blood, out of the blood. Okay, and it provides us many situation enough information.
All right, thank you so much indeed. Okay, let's have a look. There are like 4 questions left and we will be finishing. Was there anything used to treat the KIR AA plus C1, C2 combination, or what the HCG used only for the immunological abnormalities?
I told we can give some immune modulators, like corticotropin. We can use in some cases also tacrolimus. Those are this is the main medication. The HCG is also used because of the immunological abnormalities. Ovitrel, for example, I give it from the transfer until we have a positive pregnancy test. And the HCG has impact to this dialogue between embryo and the NK cells, and we know that it alters the response of the NK cells to the embryo, to the desired one.
All right. Again, thanks so much. And let's have a look at this question as well. Can immune system be over-suppressed using immune therapy through use of Humira, etc., potentially compromising implantation?
Yes, sure. For this reason, we should be very, very, very careful what we use, not to give this medication without a strict indication. And this is also the reason why we approach every case, every patient individually. We have here a board together with our immunologist. We draw the best treatment for you. It's not like a fast food, everybody gets the same.
Wonderful. Again, thank you so much. Maybe you can have a look at this one. Anything to treat adenomyosis during IVF?
Yes. My PhD was about adenomyosis. Adenomyosis, for those who don't know the term, is a form, or it's some kind related with endometriosis, is ectopic tissue, ectopic tissue from inside that normally is inside of the uterus. And instead of being only there, it could be also in various other locations. One of those locations can be the muscle tissue of the uterus. And if it's the case, then we speak about adenomyosis. Something that I do when I have people with adenomyosis, in most cases, it's not histological confirmed, it's only a finding in the scan. You see that one of the walls, for example, is much bigger than the other wall of the uterus. Something that I do is I give antagonist, a GnRH antagonist before, like decapeptyl, for example, before I do the IVF cycle. Or something else that I do is I give Diagnostic, is anticonceptive pill as a gestagen that targets directly this ectopic tissue and downregulates you even more, so that all these active cells of adenomyosis or also endometriosis would be let's say downgraded. So this would be, for example, in your situation, to give you like Gynaecologist before the IVF cycle for like 20-30 days, and afterwards to go on with IVF with the IVF cycle, and then to do exactly the same before a transfer. This could be an approach, or decapeptyl.
Thank you. Thank you indeed. Okay, if you can clarify this one, what is the difference between ERMAP and ERA?
ERMAP, it's more better, much better. I'm joking. ERMAP is the test that we here in IVF in our life group offers, and it's a test similar like the ERA test, and we screen for some other genes than in the ERA test. This is the only difference.
Excellent.
But
Thank you
with
for
both,
that.
you can estimate the implantation window.
Of course. Thanks so much indeed. And now we will look at the final question for tonight. It's about costs. I know doctors don't like to talk about that, but perhaps you can advise how can we find out cost of ER-map immune infection biopsy?
I have the perfect solution for you.
I think I
You
know.
contact us at IVF-Spain, contact@ivfspain.com, and then you will have a lovely female voice that will explain you everything.
Yes, and as you can see, here's the email address. You can use that, and I'm sure team at IVF-Spain, they will be more than happy to help you out. So thank you so much. As I mentioned, that was our final question. So everyone, thank you for your patience. First of all, thank you for staying up with us. Thank you for your amazing questions. It's been very interesting. And Dr. Christos, again, thank you for staying here with us. We had some issues, but we've managed. So thank you for not resigning and just going ahead. It's been great to have you here.
Thank you all for your attention, and thank you very much for having me and allowing me to present you some of our success cases, and to give also our patient and also our spectators another view how it could be, and that how important it is to do our homework before going on with a transplant.
We are very happy that you were able to show it to us, of course, and I'm looking forward to some more events with you. As you can see, some patients are typing thank you for you right here. So let me just add that this has been recorded, so you will have a chance to watch this again. It will be available tomorrow on myivfanswers.com, but also on our YouTube channel. Go ahead, subscribe. That way you will be notified that it has been, of course, uploaded. And Dr. Christos, have a lovely evening. Thank you so much once again, and I do hope that we will see each other very, very soon. Everyone, have a lovely evening, and I hope to see you tomorrow. As always, we will be back. Thanks so much.
Bye-bye.
Bye.